do disease names sound so like Crohn's, colitis? It's like so ugh. Like come up with some more imaginative names. So first start
What
off
should
with
it be named? Like rainbow butt disease? The information shared on this podcast is for general educational purposes only and reflects the host's personal views and experiences. It does not constitute medical, legal, or financial advice, and no professional relationship is formed by listening to this podcast. As always, consult your own qualified advisors regarding your specific needs and practice. Thank you. Hi, Sonia. Welcome back for episode 3.
episode three is near and dear to me. It's IBD. Do you want to educate us on what IBD stands for?
So, IBD and IBS are often lumped together. People kind of think they're the same thing, different thing. They're totally different things, even though they sound super similar. So there's IBS, which is irritable bowel syndrome, and then IBD, which is inflammatory bowel disease. And that's what we're going to be talking about today. And IBD, or inflammatory bowel disease, is kind of an umbrella term. And there's two types of IBD. There's ulcerative colitis,
Mm.
and then there's Crohn's disease. And those are the two types of IBD.
Okay, so I have ulcerative colitis. So can you explain to me the difference between, and I mean, why do these disease names sound so like Crohn's, colitis? It's like so ugh. Like come up with some more imaginative names. So first start
What
off
should
with
it be named? Like rainbow butt disease?
something, yeah, because when you say Crohn's or colitis, I'm just like, ugh, it sounds like the disease is, not fun and in the gut and all about poop. So I guess that is descriptory of that. But can you explain that the differences between Crohn's and colitis?
Yes. I do like to explain to people like a little bit of how a lot of our medical terms, not Crohn's, but ulcerative colitis, for example, like everything, so many things in medicine are either the name of the doctor that discovered it or Latin based. And so you just take the organ and add itis, and that's inflamed. So colitis just means itis, inflammation of the colon. And so it's really very basic. And I tell people not all colitis is ulcerative colitis because you can have infectious colitis. So something you can get an inflamed colon from an infection like E. coli or C. diff. You can have ischemic colitis, low blood flow to the colon, and that inflames the colon. So we're very specific in our terminology, and that's for a
Mm.
purpose, right? And so ulcerative colitis is and Crohn's disease, they are both autoimmune inflammatory diseases of the bowel. And sort of the distinguishing factor between the two, and what that means is basically it's the body attacking itself as
Mm.
foreign. So for some reason the body sees the cells of the colon or the small bowel as foreign and it starts attacking them like get this out of here, this is a problem, and that's why things get inflamed. So sort of the hallmark difference, and there's obviously a lot of sort of small things, but the big difference between UC, ulcerative colitis, and Crohn's is that ulcerative colitis only affects the colon, which is the large intestine.
Mm.
And kind of by definition, it has to involve the rectum, which is the very bottom part of the colon, and then can extend anywhere throughout the whole colon. But it should not and does not affect the small intestine at all. Crohn's disease, on the other hand, can affect anywhere, I like to say anywhere from the mouth to the anus. The
Oh.
whole entire GI tract. You can have Crohn's disease of the esophagus, of the duodenum, stomach, first part of the small intestine, middle, jejunum, ileum, and colon. And so it's a very different disease in that it's more diffuse, and so it's kind of, and it can go different places than ulcerative colitis. But by definition, they're just the body attacking the GI tract.
The dedunum, is that how you say it?
Oh my God, this is like such a thing in medicine because there's two ways to say it, and it's either duodenum or duodenum.
Hmm.
And I don't really know if there is a right or wrong way. I say duodenum most of the time, but sometimes I do say duodenum. I don't know. Depends on my mood.
Yeah, I failed like human biology in grade school. I got a fat F when it came to dissection and all those parts of the body. So thank you for educating me because I don't know how to say all this stuff. If you were to like, because the colon, and maybe you can show a slide of this, like the
Yeah.
difference between Crohn's and colitis, but how long is the colon? Like if we were to stretch it out, like,
Yeah, it's about 3 feet,
wow.
but you have many, many more feet of small intestine.
Hmm.
So the small intestine takes up much more real estate in your abdomen, but interestingly, it's not it doesn't do much. Like there's all of these feet of small intestine, and they do a little bit of absorption in the middle, but like there's feet and feet of small intestine that don't do much.
So the colon's like this, like
The
a,
colon is like, I tell people, it's like an upside down U with a tail at the end. So it's like,
okay, and the anus is the tail.
no, the sigmoid colon is the tail, the sigmoid
Okay.
colon into the rectum, and the anus is just the hole that goes in. It's just your entry point.
Okay, that's what makes it holy. And what about and the small intestine? Like, what's the best way to describe that?
Well, the small intestine is all the real estate in between the colon, which is the large intestine, and the
Mm,
stomach. Um, the small intestine's like the bane of our existence in gastroenterology because there is no scope that reaches the middle of the intestine.
mm,
Well, there is something called a double balloon, but it's like nobody does them and it's really hard to get there. So, sometimes when we're training our fellows in training and, we're joking with them, we'll say, like, oh, okay, now just put on the scope extender. And they're like, because there is no such thing, right? It's just the scope is as long as the scope is. And,
mm.
you know, so it's very hard sometimes to reach the small intestine. So we have a lot of different ways we can look at it, but nothing that we can like biopsy, which annoys us because we love to get samples. But like you can do what's called a capsule endoscopy where you actually, there's a camera in like a pill and you
Hmm.
swallow it and it takes pictures of your insides and then we watch it like a video. Um,
It
there's some
takes a
imaging
tour of my
studies like,
colon.
yeah, CAT scans and MRIs that help us. But yeah, that's the
Okay.
difference.
All right. And we'll go over like my symptoms, but uh what's the research say about like how we get, let's stick with ulcerative colitis and then we'll come to, or inflammatory bowel disease. Let's talk about either of them. What is the research saying about the root cause, or what are y'all able to assess right now?
Yeah, another thing that we don't really know. I mean, we know that it's autoimmune. We know that it's the body attacking itself,
Yeah.
but we don't really know why that happens. We know it's more common in families.
Mm.
So, if your parents or siblings have an autoimmune disorder, you're more likely to have an autoimmune disorder. And we know that if you have one autoimmune disorder, like let's say you have rheumatoid arthritis or lupus or even Hashimoto's thyroid disease, that you're more likely to have another autoimmune disorder.
Mm.
And so they can coexist amongst each other. Um, why it happens, we don't really know. We think that there's probably what we call a two-hit theory, meaning there's some sort of genetic predisposition that you have towards getting an autoimmune disease, and then something else happens in the environment, like you get sick or, you're exposed to a viral trigger or something like that. Like multiple things need to happen to set off this inflammatory cascade, but we
Mm.
don't really know. And I don't think it's the same for everyone.
Yeah, there was someone who I met at Scrubs and Heels. She's wonderful, Dr. Punya De Silva. She's out in Boston, and she's Indian as well. So she was educating me on how, with first generation South Asians who've come to the United States, Canada, and England, we're getting a higher dose of IBD.
Hmm.
And they're wondering if it's epigenetic, if there's something about our parents leaving the environment of India, Pakistan, Bangladesh, etc., coming over to the United States because we're getting hit with it with a higher dosage. So don't know what's going on there, but definitely want to have Dr. Da Silva on to talk a little bit more about that. So my symptoms were like I had, and you're so ashamed to talk about your symptoms because it's really embarrassing and you don't know what's going on. Like I started off in 2001 with constipation, and then there was blood in my anus. And I got my first colonoscopy like at 20 something. I do have to admit it was like 9/11. I was a little stressed out living in New York and working in Tower 3. But they just said, no, eat more fiber. But and then when it got more serious, I saw white squiggly things in the toilet, and I'm like, what the hell is that? And it was, I didn't know it, but it was mucus. And I started seeing blood. So tell me what the like mucus and blood, like what's going on there? Like why did I deliver those to the royal throne?
um, yeah, so blood comes from inflammation. So when the inflammation happens in the colon, you'll see blood in the stool. And then mucus is basically shedding of the lining of the colon. And so, I tell people inflammation of the colon and the small bowel,
Mm.
it's a spectrum. And I like to describe it. We have all these scoring systems that help us try to Mayo 1 and Root Gares and SES scores and all these scores that we try to like standardize because we like to be scientists about it. But when I'm describing to patients what inflammation looks like, it's the same in all the GI tract, right? Because you can get inflammation from other things. Like, for example, you can get reflux esophagitis, which is inflammation in the esophagus. And inflammation means just that. It's inflammation no matter where it is. And so in the colon, it can be very variable. It can be anything from like a very mild inflammation, which almost looks like a rug burn,
Okay.
like if you were going to just have a little bit of like redness, increased vascularity, sort of just looks a little bit like a rug burn. And then there's, Mayo grade 2 inflammation, which is like you were riding your bike, pedaling it, not an electric bike, just a regular old bike, and you fell off and you scraped your arm, right? And so, if you were to take a gauze and put it on top of that scrape, you may notice a couple specks of blood or something
Yeah.
on that gauze, right? And then there's Mayo grade 3 severe colitis, which looks like you were in a motorcycle accident, right? And you fell off, and there's weeping areas and pus and ulcer, and it's just bleeding and all of that. So it's a very, very wide spectrum, but that's how I like to describe it to patients.
Okay. And the other symptom I had was um, like pain in the abdomen, or what I thought was the abdomen on the left side. And then I know I went in for a weigh-in and I was really mad at my boss because I blamed him. I like went from like 130 to 118. And I was
Hmm.
like, ah, it's the stress at work that made me lose the weight. So can you say a bit more about the abdominal pain and weight loss?
Yeah, I mean, I think, when you are in this inflamed state, you're going to have pain. And so any sort of inflammation causes pain. And so that's what that is generally derived from. There are some other reasons, but it's usually inflammation equals pain.
Mm.
As far as the weight loss, it's multifactorial. You're not eating enough because you don't feel well and things like that. But it's also when your body is inflamed, you have a higher calorie need. It's like when you have a fever, your baseline calorie need actually goes up because the body requires more calories to function when you have a fever or when you are inflamed. And so your calories go up, and there's actually some protein loss that happens in inflammation. And so that really weighs into some of the weight loss and the just overall failing to thrive, so to speak. That is actually a term in medicine. We call it FTT, failure to thrive. And I feel like that some days at the end of a long week that I'm FTT, but
Yeah.
uh,
I was
I
gonna say,
don't
is it
have.
only medical, Dr. Soyka? Because
Yes, I know, right. Um, but yeah, so that kind of it weighs in on it. But I tell people everyone's story for inflammatory bowel disease is different. So you can present any symptom can be inflammatory bowel disease. You can present with new constipation, abdominal pain, change, some change in your bowel habits, blood in the stool, black tarry stool, abdominal pain, nausea, vomiting, weight loss. Almost any GI symptom can be inflammatory bowel disease. So it doesn't mean that everybody has inflammatory bowel disease, right?
mm,
Because we all have GI symptoms from time to time. But, if there's something that's pervasive and you're feeling it more days than not, and it's affecting you, you need to get in to see a gastroenterologist because we need to make the decision of what is this.
yeah, I just remembered they used to say feed a fever, starve a cold, right? So when
Mm-hmm.
you're inflamed, you're craving more food. That makes sense. That makes sense. So yeah, I was misdiagnosed a couple of times, and I remember I was telling Dr. Ha, one of my GIs said, like I told them the symptom of the weight loss, and they said, well, most women would die to be your weight.
Mm.
And I was like, I, I didn't know what to say to that. And my sister was on the Zoom call with me or FaceTime, and she was like, "What?" So I want to have a whole podcast on what not to say to your patient, where being that losing weight is a good thing. Um, so
Yeah, I
GI.
mean, there is a time and a place for us to say, congratulations on your weight loss, right? Like if you need to lose weight because you have fatty liver and the only, treatment is weight loss and you lose weight and your fatty liver gets better, then intentionally, right? But unintentional weight loss is never good. It's
Yeah,
always spurious. And, I think this points to a bigger root problem in medicine, which is that women in general are disregarded as anxious maker uppers and, you know, not taken seriously. And it happens way more in women than men. And, that's why I feel so strongly about women being in medicine, especially in the field of gastroenterology. I mean, my patient population skews very, very female because, like you said, these things are embarrassing. People don't want to be talking about like white squirrely things in their poop and blood in their stool and pain in their anus and to somebody who's going to say like, what do you think, you have a parasite, like whatever, you're fine,
yeah,
so I think there's a lot to be said about that. But I'm
yeah.
glad that you did eventually find the right person.
Yeah, I did a couple of things on that. Like, my dad once went up to someone at a party and said, "Oh my God, you look so great! You've lost so much weight." And then she went, "Mr. Narang, I have cancer." So it's just so now whenever I notice someone's had weight loss, the first thing I say is, "Are you okay? Is it intentional?" And
Mm.
then they tell me the story because I'm very mindful after that. And after we'll talk about steroids, but with IBD, you get skinny, you get moon face, chunky, all that stuff. And I became very mindful of not going out just because I didn't want the commentary about my fluctuation in weight. So not commenting on the weight as a patient is helpful, like saying, "Oh my God, you look so skinny. It's great," particularly from your physician. And then the other thing I remember in one of my scopes, the anesthesiologist was like, "You're too young to be here. Why are you here?" And I was like, dude, like,
Right.
don't say that to me. Like, I know I'm young. Like, I wouldn't be here if I didn't want to be here, but it's not helpful. Or I had a nurse tell me, "Oh my God, your hair used to be so thick." And I'd be like, I had telogen effluvium. I didn't have enough,
Yeah.
all the stuff, no iron, all that stuff. And you go through a lot of stress when you're not making your weight and not absorbing nutrients. And they were like, "Oh my God, your hair." And I'm like, I don't need my care team telling me what I see in the mirror every day. So,
I know. I mean, I think this is like a greater problem than just, I mean, we need to be cognizant of it, right? But I think people just need to shut their mouth about the appearance of other people in general. Like I I have like the worst, I mean, I have like the worst RBF, right? Like the
what's RBF? Oh,
resting bitch
resting
face.
bitch.
Yeah. Like I'm like the poster child for RBF. And maybe I'm not a resting bitch. Maybe I'm just an angry bitch, but I don't know. But I do have that face. And it gets worse when I'm thinking, which I am a lot. And I'm always multitasking. I'm doing a lot. And we have this older male nurse at a facility that I go to sometimes. And I was just really having a day, and he had already really grinded me about a bunch of things. And he looked at me and he said, "Smile, Dr. Soyka. Life's not that bad." And I just looked at him and I said, like, this is my face. Why do you feel comfortable commenting on my face? This is how I look. Would you like it if I looked at you and said, like, "Oh, John, you look so fat. Why are you eating so much? Life's not that bad." Like, this is how I look. Don't comment on it. And he was
Yeah.
like, "Ugh." But it's true, right? Like, it's just how I look. It's just my face. For God's sakes, don't tell me to smile. Like, I could be looking at like a new diagnosis of cancer in somebody, or maybe I'm getting a diagnosis. You don't know what people are going through. I don't want to smile. Leave me alone.
Yeah. Did you ever see Dancing with the Stars when Simone Biles was on it? Like, Olympian, no, like, how many times has she won? And the host was
Yeah.
like, "You're not smiling much." And she's like, "I'm competing. I'm a professional athlete." So, just a heads up to our care team, give people grace, each other, one another, because you don't know what's going on with someone internally, mentally, emotionally, spiritually, physically. So, just give each other some grace. Okay, so we talked about some of the symptoms. How do you officially get diagnosed? And then we'll go into some of the meds.
So, for the most part, it's colonoscopy, endoscopy, sometimes paired, like I said, with some scans like CT, MRI, sometimes needing a capsule endoscopy. And then there's some blood work that can be supportive of the diagnosis. So, like, obviously, you're going to want to get just see if somebody's anemic, look at their CBC. You're going to look, there's something called inflammatory markers, which you can check in the blood, something called a CRP, which is just a generic inflammatory marker that goes up with like any inflammatory condition. But if you want to look to see if somebody has inflammation in their colon, you can actually make them submit that stool sample, which I think we talked about poop in a box last episode,
The
and
shit kit?
how fun it is to give stool samples. But you can check something called a calprotectin, which is a stool inflammatory marker. But that being said, calprotectin is only it's not only, but it's really much better to look at inflammation in the colon, especially the right side, or the left side, the distal colon. And it's really not great to look at small bowel disease. But regardless, it's a lot of things. It's not just one thing. It's not as easy as like checking a thyroid hormone, and if it's low, you have hypothyroid. It's not like that. It's a little bit more nuanced.
Yeah, you get familiar with the labs, and I know we're going to have one episode just on decoding the labs, because I'm always looking for what's in range, out of range. Like UCLA does that little green, orange, red.
Yes, yes.
But I know the stool samples, the shit kit, whatever we call it. What exactly, like, there's a lot of stress in delivering it, first of all, and then you got to scoop it out. You have a whole method to how you get it. What are you measuring in it? Are you looking at, like, I know double digits is good, low double digits is good, but what are you actually measuring in there?
Calprotectin is just an inflammatory marker. So as calprotectin goes up, we know you're more inflamed. As it
So
goes down, we know you're
you
less inflamed.
you're taking a pile of my poop and then doing what with it? Like you're putting it under a microscope or what are y'all doing?
I don't actually know how they run the assay for calprotectin. I'm not a lab director, but I don't know exactly how they check for the number, but they run it through in a test tube and I don't know, check the number. I don't know how they get the number.
All right, I'm just fascinated by that in case you can't tell. Yeah, the CBC is a regular, you want to define what that is for some of our
Just like a
viewers?
blood count. I
Blood
mean,
count.
I don't want to be too like because there's many
Technical.
tests that we can do, right? And like I said, it's very nuanced. There's not one test, and sometimes we send more, sometimes we send less, but it's basically a combination of, basic labs and sometimes stool studies and inflammatory markers, imaging, scopes, maybe a capsule. It requires a lot of upfront evaluation many times.
Okay, and then once you get diagnosed and you name it, I say you got to name it, you got to tame it, and then you got to own it. So you got a name for it. How do you tame it? Like, I know there's
Well,
stuff with
I
the
think that this would
pregnant.
be a good time. You have, when did you get diagnosed with ulcerative colitis formally?
Uh, I got diagnosed um, November 2013, and great doctor, awesome doctor. He put me on mesalamine. Um, and then mesalamine was just a drug that I took. It was la la la. It was great. I was just popping pills. And I went to Mexico and I had an ice cube. And that ice cube did me in. Like I wasn't aware that an ice cube could do me in like that. And I got a really, really, really bad flare. Like I lost weight. I was chained to the toilet for a few. Um, but before I got diagnosed, like I had weight loss, blood in the stool, mucus, and I was actually taken to the ER. They thought I had lymphoma, so that was a scary 3, 4 days. They wanted to do
Wow.
surgery, and they found cysts in my stomach, and they wanted to do surgery. And my brother-in-law, bless him, he's an internist, Dr. Amar Kumar Parimi. He was like, "You're not touching my sister-in-law. Like, we're gonna check her out." So it was very like just getting a name for it was very long because they're like, she has lymphoma. We need to go in and do surgery. We need to remove the cysts. And my brother-in-law was like, hold it, like slow down. So then I went to a GI, but people like nobody knew, right?
It's a
And
scary time.
it's terrifying because they were like testing me for lymphoma because my white blood cell, like it was bonkers, right? And then we slowed it down, got a diagnosis. I was put on mesalamine, um, which, you know, the lifestyle at that point was, hey, like, take a break, corporate America, all that stuff. Got out of that system, went to Mexico, had an ice cube, and I probably had one of the worst flares of my time. And it just kept getting worse and worse. Switched over to UCLA. Dr. Hobb boosted up my mesalamine. And when we found out I was allergic to mesalamine, like I got pancreatitis.
Hmm.
So I thought it was a UTI, went to UCLA, checked myself in. They're like, your lipase is through the roof. And I'm that 1% that gets pancreatitis.
Hmm.
And then it just went worse from the ice cube. It just got worse, and I was on Entyvio Dr. Ha wanted to put, no, we went from mesalamine to cola something. Um,
Cortisol.
Colazole. That didn't work. Then we put me on steroids. And then Dr. Ha was like, we're going to put you on Humira. And at that time, Humira was coming out with all those commercials. And it's like 1% have lymphoma and die of this, that, this. So I was in an appointment with Dr. Ha. My mom was there. And my mom just started bawling, like, was like shedding tears in front of Dr. Ha because Humira was not an option. So my mom was just, it was a very uncomfortable situation. So then I went on, before Humira, I was on Entyvio. After Entyvio didn't work, it was failed, we went on Humira. Humira was working, we jacked it up, and then we moved me to Remicade. And I was doing Remicade every 28 days. And a couple of things that helped were my sister was my medical partner because when you get diagnosed, you're really fucked up. Like you're really sad, you're crying. There was a pyramid, there were drugs being spoken to at me, and I'm like, I can't register anything you're telling me right now because all I keep thinking about is this diagnosis. So my sister would be the one that would join the calls with me and Dr. Ha and take copious notes. And then my sister taught me, okay, you need to be your own advocate. So I started note taking like bowel movements, symptoms, sending them to Dr. Ha. And then we got some success with Humira. Um, we upped it to Remy, and then I think I got into remission from 2014 when it got really bad to 2021. I was in full mucosal lining remission. So it took a long, long time to get into remission.
Yeah.
Um, and, you
So
know,
tell us a little bit. I mean, you mentioned it briefly, but so this is not abnormal for people's course with inflammatory bowel disease. Sometimes it can take a while to figure out the diagnosis or figure out the medication that's going to work. I know it sounds crazy to say back in 2012, 2013, 2014, but we've had an explosion of drugs in inflammatory bowel disease really in the last 5 years, but 5 to 7 years is really, I mean, it's been incredible what's come to the table, and we have a lot more in our arsenal now. But you mentioned kind of briefly, oh yeah, steroids, this, that. Tell me a little bit about what happens when you take steroids.
okay, so I didn't know what a steroid was until I was put on it. And
And just so everyone knows, steroid generally is prednisone. Can be
yeah,
methylprednisolone too, but usually prednisone.
and prednisone calms the inflammation. It kind of puts a
That's
fire
right.
extinguisher for the fire within my body because I'm burning up.
And we
Um,
used to use prednisone all the time. It was kind of, I mean, 50 years ago, it was all we had. And so, if I ever have patients that were diagnosed with an autoimmune disorder 50 years ago, they have real problems from long-term steroid use and dependence and things like that. We really have figured out that prednisone is the bad guy. And so we really try not to use prednisone. So if you're listening to this and you have inflammatory bowel disease and you're just treating it with prednisone, a few times a year or on even chronic steroids, please consider another opinion because that's really not standard of care anymore.
yeah.
But anyway, prednisone makes you a bunch of things. So tell us what happens when you have to calm the inflammation acutely with prednisone.
So, first of all, I'm lucky because I'm always looking for mentors, and I have a white mom in Utah who was diagnosed with ulcerative colitis. So I talked to her, and I said, "What am I in for?" And she said, "Listen up. If you ever get put on prednisone, here are some things you need to know." So I had a mentor, just like before I went on Humira, the care team put me in touch with a patient. I didn't know I could do that. I spoke to a patient and she walked me through the experience. So what I learned on prednisone was it did calm the fire. It did work for a short amount of time. My face got puffy. My belly got big. I gained about 20 pounds. I was like the Hulk. Like my Pilates teacher was like, "You're doing 2 workouts a day and you're still not tired." I'm like, I just have so much energy. I was very punchy. I was angry. I couldn't sleep. Like my mind was always on fire. Like I just had a ridiculous amount of energy, and I thought there were some days where I was just losing it. And I was super hungry. I was eating all the time, like all the time. And I was like, you know what? This is gonna be my bosomy phase of life. Like I'm just gonna embrace the bigger boobs, the bigger butt, baby got back, all that stuff. I was
Your
like, all right.
voluptuous phase?
Yeah, I just want buxom. I was like, let me enjoy this phase and let me eat whatever the fuck I want. But then I hid because I'm from a Indian community which digs, right? Like people make comments all the time about your weight and why aren't you married and what's wrong with you and this and that. That's a whole nother episode. So I hid from people that I knew were gonna like shame me for my weight. And one of my friends, J Rod, she works with foster kids. So what we did, and I hope any patient is listening to this, I made a handle with care email. So I started sending to my coworkers, to my friends and my family, handle with care. I'm on prednisone. Here are the symptoms. Here's what's going to happen to me. And here's what I need right now. Like I'm punchy. I have a short attention span. I might need to get up and use the bathroom. I might need to go exercise ridiculously. I am not myself right now, so I'm asking for grace. And that handle with care, like email, post it, whatever I created, was a game changer. Having a mentor, the handle with care, and really embracing this like more voluptuous me, going to Macy's, going to Target, buying clothes that were bigger, because we had to put the fire out before we could get me stable on Humira and Remicade, and now I think I'm on Stellara. So um, it was, we call that whole time from 2014 to 2021, my friend Jenny calls it dark and stormy because
Oh, I love a dark and stormy.
it's a great
Have you
drink,
ever? I
right?
love that drink. Yeah.
Such a good drink, but she's a marketing genius at the NBA, and we just call that time dark and stormy. But I learned a lot, which is surrender. Like, one, be a medical advocate, take your own notes, be on top of it, get fluent with the drugs, have the conversations with your doctor. And two, like, you really need not a village, you need a fucking country to support you through that. Like, really
Yeah,
give.
I was gonna say, I think what I hear you saying a lot is it's hard, it's really hard. And you can't go through it alone. And if that doesn't mean you have to be married or have, the most supportive family, we have lots of resources through the drug companies, through Crohn's and Colitis Foundation, through IBDSA, through all of these different associations where, there is mentorship programs and buddy systems and, let us help you because nobody can go through it alone. And so I'm glad you had a support system, and I hope if people feel like they're struggling and they're alone, that they reach out to their doctors and tell them because I tell people all the time like I don't know what you're going through unless you tell me. So we there needs to be open lines of communication with your patient and with the doctors, and everybody needs to feel comfortable chatting it up.
Yeah, and only I think I said this at Scrubs and Heels 2 years ago. Like, you kind of have to grieve the life you thought you were gonna have and go through that and then embrace the life you get to have, right? Like, but you
Yeah,
need.
I mean, I think there's that, right? Like I tell people, yes, but my goal is to get you back to the life that you always had. You'll have gone through something hard, but my goal is always get you into remission and keep you into remission. So we've got kind of a couple minutes left, but I want to talk about as briefly as we can about drugs because we touched on prednisone. We talked about how it's, like the worst drug in the world, but sometimes it is needed. There's lots
I
of other
call
drugs
it
in,
Satan's drug.
right. Satan's drug to stop Satan's butthole. But I think, I'm not going to get into everything, but you mentioned there's a pyramid and there used to be this sort of safety pyramid and all this stuff, but everything is kind of getting turned on its head in the world of IBD right now because of the boom of drug development. And I would say, we have some of the safe drugs on the market right now. They are incredibly safe. And yes, the biggest adverse effect of these drugs is increased risk of infection because like we said at the beginning, Crohn's and UC are autoimmune disorders. They are attacking your immunity. They attack your immune system. So the only way to quiet them down or target that is to target the immune system that is being affected. And so by default, if you're lowering somebody's immune system, you're going to be more prone to infections.
Mm.
But other than that, there is very little risk. I mean, sure, there is a very small, maybe theoretical risk of this rare non-T cell lymphoma that may happen. I've never seen it, and I, consider myself sort of a specialist in inflammatory bowel disease. Maybe in non-melanoma skin cancers, but they're very safe drugs. And I tell people the fact is that any uncontrolled inflammatory bowel disease, so colitis, Crohn's disease, that is not under control has a higher risk of what we call in medicine morbidity and mortality, meaning you have a higher risk of complications from your inflammatory bowel disease than you do from the drugs.
Can
And
you
so that's I feel like just a really big point that I'm always trying to get across to my patients is like the drugs are not the problem. The disease is the problem. And not
preach?
controlling the disease
Yeah.
is what is going to lead to most of the problems.
Yeah.
And drugs are scary, and then they're on the TV like, you could, be shitting your pants for 67 days and, maybe your uncle might get syphilis and like all these crazy side effects. And, they're not, they can't really say, the other stuff, which is if you don't control your inflammatory bowel disease, you're going to end up in the hospital anyway.
Yeah, no, good. That's an excellent point. I have immigrant parents who are very afraid of doctors and medication, so that was a whole education for them. Because they were like, just eat turmeric, and I'm like, this ain't gonna be fixed just by having turmeric, Like we need to address it. But in a nutshell, can you explain what all these different drugs do, whether it's Entyvio, whether it's Humira, Remicade, what are they trying to do to the colon? What or to
Yeah, they're trying to
some
decrease the
line?
inflammation and bring, healing to the mucosa and, basically have no evidence of any inflammatory bowel disease. Restore you so that if I'm looking in your colon, it looks like somebody without inflammatory bowel disease.
Yeah. And they work. They
They do.
work. Yeah, they
I
work.
think one of the biggest questions people ask me in regards to medications with inflammatory bowel disease is, do I have to be on this medication for life? That is probably one of the most common questions people ask me. And I say, one, I don't know. Two, I need you to be on it for the indefinite future. And that point of when and if we consider stopping it remains to be seen. Um, you know, it is different. Like I said, every patient with inflammatory bowel disease is different. Not one patient has had the exact same course as another patient in my experience. Every single one is different. It's why I actually love it because it keeps me on my toes and I like to think. And, I remember thinking about what field I wanted to go into, and I was thinking about cardiology. And I remember thinking like, oh, but you know, cardiology is so easy. Like, it's
Hmm.
just the heart, and we know everything about the heart and the muscles and the vessels, and all the cardiologists that are listening to this are probably gonna like hate mail me right now. But I remember thinking like the GI tract is so much more diverse, and there's so much we don't know, and it's so heterogeneous, everybody being so different. So it's one of the things I love about IBD, but it's also very frustrating simultaneously, is that, we expect you to behave a certain way, but you don't, and you don't respond like we want you to, and then we have to try it again. But anyway, the answer to that question, in case you're wondering as a patient, is maybe.
Yeah. Yeah, I'm okay. I think of it as a big experiment, and um now we're on a different drug, and I have less upper respiratory infections, but then I have to be more mindful. Like I ate too much candy for Halloween. Like I dressed up in Elmo pajamas with my friend Melina, and I just went at it to town with Halloween candy. And then I was like, ooh, that mixed with a tamarind and like a roti with, I don't know, pumpkin. My auntie put pumpkin. I was like, right, this is a flare. So you live life, you go large, and then you come back home, and you're like, okay, I'm flaring, and but it's nice not to be on the prednisone as much. It's a game changer now. And I'm very grateful for the meds, my care team, and the country of people that support me through the good days and the bad days. So you do have to, you might not grieve your life, but you reimagine it a little differently. Like I grieved it, but you do reimagine it differently. And we'll talk about spoon theory. I just introduced that concept for a couple of my friends about how many spoons you have in a day for an autoimmune. So there are some other things we can talk about. But yes, I appreciate this discussion. Any other parting words for our listeners today?
No, I mean, I think, we talked a lot. There was a lot of data in this one. It was a data heavy talk. But, if any of this is making you think, you know, come and see us in GI. I think it's always worth talking to a gastroenterologist if there's any concern, because, I always say like IBD is the great masquerader. It likes to present, it can present as anything, right? It doesn't
Mm,
even have, I said all these GI symptoms, but, I diagnosed a young girl today with inflammatory bowel disease whose main complaint for 10 years has been joint symptoms. And so her arthritis was IBD arthritis. And so even though we think we know everything, we know, you never know, right? And so if there's any concern, talk to your doctor.
I think that's the main thing. Like it is, you feel so ashamed of what comes out of you in the toilet or some of these symptoms, and you think you're losing it, and just talk to someone because someone somewhere feels it. It's just you have to get through the hurdle of sharing it.
I mean, you've heard me say this before. We normalize the boob. We have to normalize the
Yeah.
colon. We've got to normalize the shit talk
Yeah.
because, with colon cancer on the rise and autoimmune diseases on the rise and all this literal shit, we've got to be talking the shit to
Yeah,
deal with the shit.
I was sitting next to an oncologist at a medical conference at UC Irvine, and he was like, "Man, these GIs talk a lot about poop," and I was like, "Oh, our humor is not that I'm a physician, but we have very dark poop humor."
I mean, but seriously.